Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session I will be discussing a very important topic in the neurology, that is epilepsy. So we have three important terminologies in the epilepsy that we need to know, that is you need to know what is seizures, you need to know what is epilepsy, and you need to know what is convulsions. So these three terminologies you should be very much aware of. Okay, so if you take the word seizure, it is an involuntary movement, right? But this particular seizure, it is due to uncontrolled episode of the brain dysfunction, right? So there will be a sudden transitory uncontrolled episodes of brain dysfunction, right? And this sudden transitory uncontrolled episodes of brain dysfunction, they result from abnormal discharge of the neuronal cells. Resulting from abnormal discharge of neuronal cells, right? And these individuals with seizures, they have abnormal motor, sensory or behavioral changes. So in case of a seizure, it is a single episode or a single event of uncontrolled episodes of brain dysfunction. This uncontrolled episodes of brain dysfunction, it is resulting from abnormal discharge of neuronal cells. Now, in these patients with seizures, why exactly there will be abnormal discharge of the neuronal cells? So, this abnormal discharge of neuronal cells, they occur mainly due to release of the excitatory neurotransmitters, right? They occur due to release of excitatory neurotransmitters. And what are those excitatory neurotransmitters that are being released? That includes aspartate and as well as the glutamate. These are the excitatory neurotransmitters which are released in excess quantity. And this excitatory neurotransmitter which are released in excess quantity, they cause paroxysmal, that means sudden, right? They cause paroxysmal hypersynchronous discharge of cerebral neurons. Right? Paroxysmal discharge or paroxysmal hypersynchronous discharge. Of cerebral neurons, right? So that is what is the reason why you will have the seizures. So seizures, it is a single episode of involuntary motor abnormal sensory or behavioral changes. And these particular seizures, they appear due to paroxysmal hypersynchronous discharge of cerebral neurons. And this paroxysmal hypersynchronous discharge of cerebral neurons, they occur due to release of excitatory neurotransmitters, that is aspartate and as well as the glutamate. Now, the next important terminology that you need to know is the epilepsy. Epilepsy, it is not a single episode like seizure. Epilepsy is a chronic condition. Right? Epilepsy, it is a chronic condition. And this particular epilepsy, which is a chronic condition, it is characterized by 2 or more unprovoked seizures. Right? 2 or more right? 2 or more unprovoked seizures. That will be your epilepsy. Right? It is same seizure only, but 2 or more episodes of seizure together will form what is called as an epilepsy. And what is convulsion then? See, in case of a seizure episode, you have an abnormal motor activity, abnormal sensory sensations, and abnormal behavioral changes. Now, the motor manifestations of epilepsy is called convulsion. Right? Motor manifestation. Right? Motor manifestations of epilepsy. Right? So this is what is nothing but your convulsion. Okay? So these are the 3 important terminologies. One is seizure, second is epilepsy, and then third one is the convulsion. Now, having said about these 3 terminologies, now let me discuss the classification of this epilepsy. So seizures or epilepsy can be classified or divided into 2 major classifications based on their origin. Right? So based on their origin, we classify the epilepsy into 2 types. Number 1, it is your neurogenic seizures. Right, where the abnormality is within the cerebral hemispheres, and the other form, the other part of the classification is the psychogenic seizures. Right, the other one is psychogenic seizures. And this particular neurogenic seizures, they result from excessive discharge of cortical neurons. Right, that is due to excessive discharge of cortical neurons. That is what is your the classification based on their origin. Whereas you take psychogenic seizures. What are psychogenic seizures? Psychogenic seizures are non-epileptic seizures. They are increasingly common and may be extremely difficult to distinguish from the true seizures. These psychogenic seizures, they are also called as they are also called as the pseudo seizures. And these pseudo seizures are not the result of abnormal cortical discharge. They are often associated with major stress or emotional trauma. Right? So these psychogenic seizures or pseudo seizures, they result from major stress or emotional trauma, right? So that is what is your psychogenic seizures. Okay. Now, having said about the neurogenic seizures and psychogenic seizures, this psychogenic seizures, let me tell you, they are little difficult to fit into a single class of seizures. They come under an unclassified seizures. Now, you take neurogenic seizures. Again, we subclassify these neurogenic seizures into two main groups depending upon their manifestation. Now, what are those two main subgroups of the neurogenic seizures? The two main subgroups of the neurogenic seizures include, number one, the generalized seizures, and the other one is the focal seizures. You take the generalized seizures. Generalized seizures, they involve abnormal neuronal activity in both the cerebral hemispheres, right? So there will be abnormal neuronal activity in both the cerebral hemispheres. Right, abnormal neuronal activity in both the cerebral hemispheres of the brain. And these patients with the generalized seizures, they are being accompanied by loss of consciousness. Right, they are being accompanied by loss of consciousness. Which one? The generalized seizures. Whereas you take the focal seizures. Focal seizures, the abnormal neuronal activity is not in both the cerebral hemispheres. The abnormal neuronal activity, it is present only in one cerebral hemisphere. Right, and that too in a part of the cerebral hemisphere, there will be origin of abnormal neuronal discharge, and that will result in the focal seizures. Then, how do you classify the generalized seizures? Generalized seizures, they can be further characterized based on the pattern of motor activity, right? Based on the pattern of motor activity, they are being further subclassified. They are subclassified into tonic, clonic, then tonic-clonic, atonic, and then myoclonic epilepsy. And we have another form of epilepsy called absence seizure, generalized seizures, that is called absence seizures, right? So these are the various forms of generalized seizures based on the pattern of the motor activity. So you take this tonic. Tonic seizures are those, the pattern of motor activity is like the individual will have a rigid trunk and extremities. Characterized by rigid trunk and extremities. That will be tonic seizures. Whereas clonic seizures are those which are characterized by symmetrical rhythmic jerking of trunk and extremities. right? Symmetrical, rhythmic jerking of trunk and extremities. That will be your clonic seizures. Tonic-clonic, if you see, it is the disorder where the individual will have a tonic phase which is followed by the clonic phase, right? That is what is your tonic-clonic seizures. Atonic seizures are those which are characterized by sudden loss of postural tone. Right, sudden loss of postural tone. That is what is called atonic seizures, where there is absence of the tone. Whereas myoclonic epilepsy or myoclonic seizures are those which are characterized by brief, shock-like muscular contractions. Right, brief, shock-like muscular contractions. Right, so that will be your myoclonic epilepsy. Absent seizures are those where commonly seen in children which are characterized by absence of the involuntary movements. But what will be there in absent seizures? Then the individual will be motionless for few seconds. That means the individual will be completely static. He does not have any involuntary movements. He just have a staring look. That is what is your absent seizures. So this is like based on the pattern of motor activity, the generalized seizures are further being subclassified. Then you take the focal epilepsy. What is focal epilepsy? See, previously this particular focal epilepsy, we were calling it this as partial epilepsy, right? We were calling this as the partial epilepsy. So this particular focal epilepsy or partial epilepsy is that which involves the neuronal discharge in a localized area of one cerebral hemisphere, right? This involves neuronal discharge of or neuronal discharge in a localized area of one cerebral hemisphere. Right, localized area of one cerebral hemisphere. And this particular focal epilepsy, they are further subclassified into two types. One is your simple partial epilepsy, and second it is the complex partial epilepsy. Simple partial epilepsy, right? Simple partial epilepsy is that where consciousness is maintained whereas complex partial epilepsy is that where there is impaired level of consciousness. right, where there is impaired level of consciousness. That is what is your the complex partial epilepsy. So in both of them, either you take in simple or complex partial epilepsy, the abnormal neuronal discharge will be in the localized area of one cerebral hemisphere. But in case of simple, the consciousness of the individual is being maintained. Whereas in complex partial epilepsy, there is impaired level of consciousness. That is what is your focal epilepsy. Then, what is the most common cause of the status epilepticus? Okay, first of all, you need to know what is status epilepticus. This is another form of the epilepsy. Status epilepticus, it is the clinical scenario where the individual will have a continuous episodes of seizures, right? The individual will have, right, SZ stands for seizures. The individual will have continuous episodes of seizures. But what is the importance of, what is the important point in this continuous episodes of seizures is that the individual will be in a state of loss of consciousness between the episodes, right? So the individual will be in a state of loss of consciousness. LOC stands for loss of consciousness, right? So let me tell you, these patients, they will not have a complete recovery of consciousness in between, right? They will not have complete recovery of consciousness in between. And this entire episode, right? This entire episodes, they last for more than 30 minutes. Right? They last for more than 30 minutes. That is what is your status epilepticus. And the other way by which you can define this status epilepticus is, that is, single episode of seizures that will be lasting for more than 5 minutes. Right, that will be lasting for more than 5 minutes. That is what is also called the status epilepticus, right? And the most common cause of status epilepticus is discontinuation of anticonvulsant medication, right? So most common cause will be discontinuation of discontinuation of anticonvulsant medication. That is what is your status epilepticus, most common cause for the status epilepticus. Then followed by that, you need to know most common type of epilepsy or most common type of seizures in neonates. So the most common type of seizures in neonates will be the subtle seizures. Right, that will be the subtle seizures. And the most common type of seizures in children, they are called as the febrile seizures. Right, most common type of seizures in children, they are called the febrile seizures. These febrile seizures, they are also called benign Rolandic epilepsy. Right, they are called as benign Rolandic epilepsy. Now, why is it called benign Rolandic epilepsy? Because it begins in Rolandic fissure. Right, it begins in Rolandic fissure. Right, so that is the reason why it is called the Rolandic epilepsy. Now, this Rolandic fissure, it corresponds to right? It corresponds to area number 4, which is nothing but motor homunculus, right? Which is nothing but motor homunculus. And the most common type of seizures in individuals less than 18 years will be GTCS, right? Generalized tonic-clonic seizures. And in individuals around age group of 18 years, this particular GTCS most commonly occurs due to drug abuse. So, if you see, the most common cause of seizures in adults more than 35 years, that would be secondary to cerebrovascular accidents. So, these are the common causes of seizures in neonates, children in age group less than 18 years, and as well as adults more than 35 years, right? Now, having said this, let me discuss about the generalized tonic-clonic seizures, which is one of the most common form of the seizures. So, if you take the most common epilepsy in adults, right, that will be the generalized tonic-clonic seizures. And this generalized tonic-clonic seizures, the other name of it is called as grand mal epilepsy, right? Other name of it is called as grand mal epilepsy. And this particular generalized tonic-clonic seizures, it is characterized by violent jerky movements, right? Characterized by violent jerky movements. And these individuals, they have frothing from the corners of the mouth, right? They have frothing from the corners of the mouth. And even if you take the eyeballs, there will be uprolling of the eyeballs. And what about the tongue bite? Tongue bite may or may not be present. Right? Tongue bite may or may not be present. And what about what happens to the bladder and bowel? So, if you take the bladder and bowel, there is urinary incontinence, right? Regarding the bladder, there is urinary incontinence, and regarding the bowel, there is stool incontinence. Right? Regarding the bowel, there is stool incontinence. And what will be the duration of this generalized tonic-clonic seizures? The duration of this generalized tonic-clonic seizures is around 30 to 60 seconds. That is the duration of the generalized tonic-clonic seizures. And these individuals, they have the premonitory symptoms. So, the patient is uneasy and irritable hours before the attack, right? The patient is uneasy and irritable hours before the attack. That is what these will be the premonitory symptoms, right? The patient is uneasy and irritable hours before the attack. And these individuals, they also have the aura, right? And this particular aura is nothing but the abnormal sensations that the individual feel before the onset of the episode. So that particular aura, we call it as the individual can have an abnormal feeling of sensation of smell, that we call it as an olfactory aura, or the individual will have an epigastric discomfort. Right, the individual will have epigastric discomfort. This will be another form of the aura. And initially they'll have tonic movement, then followed by that the clonic movement. So tonic movement, I have already said you what is tonic movement. That will be there for nearly around 10 to 30 seconds, and clonic movement will be there for nearly around 1 to 5 minutes, and that will be a violent jerking of the limbs, right? That will be violent jerking of the limbs. And these patients, they also have the postictal deficit, and that postictal deficit will be in the form of that postictal deficit will be in the form of unconsciousness. That postictal deficit will be in the form of the flaccid limbs. That postictal deficit will be in the form of absence of corneal reflexes, and that postictal deficit can be in the form of extensor plantars for few hours. Right, that will be in the form of extensor plantars for few hours. So this will be the postictal deficit, and this is what is the description of the generalized tonic-clonic seizures. And at the same time, you need to know what is the cause of death in these patients with the GTCS. In patients with the GTCS, right, after an episode, the individual go into a state of unconsciousness or an altered sensorium. So during that altered sensorium or unconsciousness, the individual can have the development of aspiration pneumonitis. Right, aspiration pneumonitis. That would be the cause of death. Because of hypersynchronous discharge of cerebral neurons, there will be involuntary movements, and due to which the individual will have hyperthermia, and then there can be metabolic acidosis. Right? So these are the causes of death: aspiration pneumonitis, hyperthermia, and as well as the metabolic acidosis. And in case of generalized tonic-clonic seizures, what will be the drug of choice? The drug of choice for generalized tonic-clonic seizures will be valproic acid. Right, it will be valproic acid. That will be the drug of choice for generalized tonic-clonic seizures. Now, you need to know, after having discussed about generalized tonic-clonic seizures, let me discuss about the absence seizures. So generalized tonic-clonic seizures, what was the other name? The other name of generalized tonic-clonic seizures was grand mal epilepsy, right? And in generalized tonic-clonic seizures, there will be abnormal neuronal discharge in both the cerebral hemispheres, due to which the individual will have tonic and clonic movement in all over the parts of the body. Right, the individual will have tonic and clonic movement in all over the parts of the body. And these patients with generalized tonic-clonic seizures, right, these patients with generalized tonic-clonic seizures, they have to be given valproic acid to subside that hypersynchronous neuronal discharge. Having said that, let me discuss about the absent seizures. Absent seizures are seen in grand mal epilepsy, myoclonic epilepsy, petit mal epilepsy, hyperkinetic child. So the other name of the absent seizures, it is also called as the petit mal epilepsy. So the other name of absent seizures are petit mal epilepsy. And this absent seizures or petit mal epilepsy, it is characterized by sudden. You take the seizure itself, it appears abruptly, paroxysmally, suddenly. Right? So even the same, this absent seizures or petit mal epilepsy, it is characterized by sudden, brief lapses of unconsciousness. Right? Characterized by sudden, brief lapses of unconsciousness, and followed by a brief lapses of unconsciousness. These individuals, they will have a normal life, in the sense they will not have, right, there is no loss of postural control. Right, there is no loss of postural control. That is what is your absent seizures or petit mal epilepsy, right? So it is the epilepsy which is characterized by sudden, brief lapses of unconsciousness without loss of the postural control. And if you take the duration of these particular absent seizures, the seizures typically last only for seconds. Right, only for seconds. And in these individuals, the consciousness returns as suddenly it was lost, and there is no postictal confusion. Right, so consciousness returns back to normal immediately. Right, consciousness will return back to normal immediately, and there will be no postictal confusion. Right, there will be no postictal confusion. And in the postictal state, the individual will have a normal life without loss of consciousness and without loss of postural control. Right, without loss of postural control. Right, so that is what you will have in the postictal state. And these absent seizures, they are usually accompanied by subtle bilateral signs. Right, they are usually accompanied by subtle, that means very minimal. Right, usually accompanied by subtle bilateral signs. And what will be that bilateral signs? Such as rapid blinking of the eyelids, right, such as rapid blinking of the eyelids. There can be also right, there can be also chewing movements, or there can be small amplitude of clonic movements of the hand. Right, small amplitude of clonic movements of the hand. That is what is the accompanying feature of the absent seizure. And few more characteristic features of the absent seizures or petit mal seizures, if you see, these absent seizures, they are notable for their short duration of action. Right? They are notable for their short duration of action. That means these episodes will be there only for a shorter duration, that is for few seconds. And during these particular episodes, there will be paucity of motor activity. Right? Paucity of motor activity. Right? See, sometimes these episodes are so brief that the patient sometimes are not even aware of them. Right? The episodes are brief. Right? The episodes are brief that sometimes patient, right? Sometimes patient is not aware of the event. Right? Sometimes even the patient is not aware of the event. Right? And these particular attacks, they come without warning. Right? These attacks, they come without warning, and they consist of a sudden interruption of consciousness. Right? They consist of right? They consist of sudden interruption of the consciousness. Right? So that will be the some of the few more features of the absence are the petit mal seizures. And the patients will have a staring look during the episode, and they will briefly stop talking or ceases to respond. Right? There will be no response at all. Okay? And we have another form of absent seizures that is called as atypical absent seizures. An atypical absent seizure has less abrupt onset. That means they will be having a gradual onset. So there is a less abrupt onset and offset. Right? Less abrupt onset and offset of loss of awareness. Right? Less abrupt onset and offset of loss of awareness compared to that of typical absent seizures. See, in case of the typical absent seizures, they have abrupt onset of episodes, but whereas in atypical absent seizures, they have less abrupt onset and as well as offset. And these particular atypical absent seizures, they are often associated with other features. Right? They are often associated with other features such as loss of muscle tone of the head, right? Such as loss of muscle tone of the head. There can be loss of muscle tone of the trunk, or the limbs. And they can also have a subtle or a minimal myoclonic jerks. Right, a subtle myoclonic jerks. So these will be the features of the atypical absent seizures, right? So atypical absent seizures are those where they have less abrupt, where they are like less abrupt in onset and offset of loss of awareness than compared to that of typical absent seizures, and they are often associated with other features such as loss of muscle tone of the head, trunk or limbs, and they can also have a subtle or a mild myoclonic jerks as well. And if you take the frequency of these particular absent seizures, so they have a high frequency. Right, they have a high frequency. You know, the number of episodes, they may be, right, almost like several hundred episodes may occur in a single day, right? Even there can be up to 100 episodes per day can also be there. Sometimes they occur in a burst, okay? And these attacks of the absent seizure, they are precipitated by hyperventilation. So whenever the individual does hyperventilation, then the attacks, they get precipitated, and these particular attacks, they also get precipitated by photic stimulation, right? They also get precipitated by photic stimulation. So that is how the attacks, they get precipitated. And these particular attacks of the absent seizures, they stop by the age of 20 years. Right? They stop by the age of the 20 years. That is about the absent seizures, the features of the absent seizures. And these absent seizures are characterized on the EEG by 3 Hz spike and wave pattern, 1 to 2 Hz spike and wave pattern, generalized polyspikes, hips arrhythmias. So, if you take the EEG pattern in case of the absent seizures, the EEG pattern, they have generalized, right? They have generalized 3 per second spike in wave pattern. Right, 3 per second spike in wave pattern. So that will be the EEG pattern in case of the absent seizures. So absent seizures are seen in what? Seen in petit mal epilepsy. Now you should know, okay, you see, absent seizures are characterized on EEG by 3 Hz spike and wave pattern, 1 to 2 Hz spike and wave, generalized polyspikes and hips arrhythmias. So it is 3 Hz spike and wave discharge. And these patients with absent seizures, they re-establish full contact with the environment and they resume pre-seizure activity. There is no postictal confusion in case of the absent seizures. And you see other question. All of the following are the features of the absent seizures except usually seen in childhood, 3 Hz spike and wave in ECG, postictal confusion precipitated by the hyperventilation. So postictal confusion will not be there in case of the absent seizures. And the next question is, which of the following is the drug of choice for absent seizures? Phenytoin, valproic acid, carbamazepine, phenobarbital. So the drug of choice for absent seizures will be the valproic acid, right? So again, let me tell you, in age group less than 3 years, the drug what we give is ethosuximide, and in individuals more than 3 years, we give valproic acid. See, valproic acid is associated with the hepatotoxicity, and that particular hepatotoxicity of the valproic acid cannot be tolerated by an individual or by a child less than 3 years. So that is the reason why we don't give this valproic acid in individuals less than 3 years. Now, so next coming on to the focal seizures. So focal seizures, I have already said you that these individuals, they'll have the abnormal neuronal discharge in one particular area of a cerebral hemisphere, and that area, whichever or that particular area of the brain, if it is concerned with the motor activity of the hand, the abnormal motor movements will be there within the hand. Or if that area of hypersynchronous neuronal discharge, if that area is concerned with the leg, then there will be abnormal involuntary movement within the leg. So accordingly, you will have that involuntary movements. So if you take the motor manifestations, the activity, the hypersynchronous discharge, it arises in the precentral gyrus. Right, it arises in the precentral gyrus, right, and this precentral gyrus, it corresponds to the motor area, right, and this abnormal neuronal discharge, whichever is arising in the precentral gyrus, that will cause, or that is responsible for the partial seizures. Right, which is nothing but the focal seizures. And as I have already said you, that abnormal motor activity may be there either in the arm or in the trunk, but it will not be on the same side of the cerebral hemisphere, that will be on the contralateral arm. Right, that will be on the contralateral arm and trunk. And sometimes the attacks, they begin in one part, right, they begin in one part. Like we have a form of epilepsy called Jacksonian epilepsy. Now, what is this Jacksonian epilepsy? It is a form of your focal seizure. So here, in case of the Jacksonian epilepsy, the attack, it begins in one part of the body. Right, attack begins in one part of the body. Right, this one part of the body, it can be either in the thumb, right, this can be either in the mouth, or this can be either in the great toe. So in either of these areas, that abnormal involuntary movements, they begin, and then they gradually spread off the entire body. Right, from this area, they gradually spread right, they gradually spread to the entire body. That is what is called as the Jacksonian epilepsy. Right, so Jacksonian epilepsy is that where the involuntary movements, they begin at one part of the body and they spread to the entire body, and that is what is nothing but Jacksonian epilepsy. Then we have another form of the focal epilepsy, that is called Todd's palsy, right? You need to know what is this Todd's palsy. See, whenever there is prolonged episodes of seizures, whenever there is prolonged episodes of seizures, these prolonged episodes of seizures are associated with, they are associated with weakness of the limbs. They are associated with weakness of the limbs. And that is what is called as the Todd's palsy. Prolonged episodes are associated with the weakness of the involved limbs. That is what is called as the Todd's palsy. Now, in case of these particular Todd's palsy, let me tell you, you will not have only motor abnormality. There is also the sensory abnormality as well. But for an individual to have a sensory abnormality in case of the focal seizures, the hypersynchronous discharge or the activity arises in postcentral gyrus. Activity arises in postcentral gyrus, causing electrical tingling sensations. Causing tingling sensations within the extremities. And these individuals with the focal seizures, they also have the versive movements. Now, which group of individuals will have these versive movements? Wherever there is frontal epileptic focus. Wherever there is frontal epileptic focus, there you have the versive movement. Versive movement is that where there is conjugate deviation of the eyes. Where you have conjugate deviation of the eyes. That is called versive movement. Then these individuals with the focal seizures, they also have the visual impairment. And this particular visual impairment, it is characterized by visual hallucinations. Characterized by visual hallucinations. And this particular visual hallucinations, the visual hallucinations of the faces, visual hallucination of the images will be there. So this will be visual impairment in case of the focal epilepsy. And what about aura? Let me tell you, in case of focal epilepsy, aura is not seen. Aura is not present. Whereas aura, it is present in case of the generalized tonic-clonic seizures, but not seen in case of the focal seizures. Then these individuals, they also have psychomotor abnormality. That is, there will be alteration there will be alteration in the mood of the individual, alteration in the memory, alteration in the perception. So alteration in the mood, memory and perception. And this psychomotor abnormality in case of the focal epilepsy, that is what is called as the temporal lobe epilepsy. So in order to have these abnormalities, the abnormal neuronal discharge will be there from the abnormal neuronal discharge will be there from the temporal lobe. And these patients with the focal epilepsy, they have automatisms. So automatic movements like automatic movements like lip smacking, automatic movements like picking movements, automatic movements like abnormal facial expressions, all that can be seen in case of the focal epilepsy. And what is the drug of choice in case of focal epilepsy? Drug of choice in case of focal epilepsy will be drug of choice in case of focal epilepsy, it will be carbamazepine. So that is about the focal epilepsy. So in case of focal epilepsy, you have abnormal motor, sensory and abnormal visual versive psychomotor abnormality will be there. So in order to have abnormal motor activity, the origin of the impulse is from the precentral gyrus, causing partial seizures affecting contralateral arm and the trunk. And you also need to know what is called Jacksonian epilepsy, where the abnormal movements, they start at the one part of the body like mouth, thumb or great toe. Followed by that, the abnormal movements spread throughout the body, that is called Jacksonian epilepsy. Then we have Todd's palsy. Todd's palsy is like where whenever there is prolonged episodes of these focal seizures, there will be weakness of that particular involved limb, that is called Todd's palsy. And these individuals, they also have abnormal sensory activity in the form of tingling sensations. And this abnormal sensory activity, it arises, the hypersynchronous neuronal discharge arises in the postcentral gyrus, and versive movements where there is conjugate deviation of the eyes, and that is due to frontal epileptic focus. And visual impairment in the form of hallucinations of the faces, hallucinations of the images, and there is no aura in case of the focal epilepsy. And psychomotor abnormality will be in the form of alteration of the mood, memory and as well as perception. And these individuals, they have associated automatic movements, or we call it as automatisms. So that is about your focal epilepsy. Then followed by that, the next important form of epilepsy is the juvenile myoclonic epilepsy. All of the following are the features of the juvenile myoclonic epilepsy except myoclonus on awakening, generalized tonic-clonic seizures, automatisms, absent seizures. So if you take this juvenile myoclonic epilepsy, it is also called as Zan's syndrome. Juvenile myoclonic epilepsy, it is also called as Zan's syndrome. And this particular juvenile myoclonic epilepsy, which is also called Zan's syndrome, it is present in adolescents. Present in adolescents. These patients with juvenile myoclonic epilepsy, in future years, they will develop in future years, they will develop generalized tonic-clonic seizures. In future years, they will develop generalized tonic-clonic seizures. And this particular juvenile myoclonic epilepsy, this is the most common form of idiopathic generalized epilepsy in older children and young adults. So this will be the most common form of idiopathic generalized epilepsy idiopathic generalized epilepsy in older children and young adults. right? Older children and young adults. And this particular juvenile myoclonic epilepsy, as I have said you, it is seen in adolescents. And which particular age group? Around the age group of 15 years, you will come across this juvenile myoclonic epilepsy. And this juvenile myoclonic epilepsy, let me tell you, it is characterized by a triad. And this particular triad include, number one, myoclonic jerks. Number two, generalized tonic-clonic seizures. Number three will be the absence seizures. Right, number three will be absence seizures. So this is a triad like what you will see in case of juvenile myoclonic epilepsy. Right, they'll have myoclonic jerks, they have generalized tonic-clonic seizures and absence seizures, which is also called petit mal epilepsy. And these patients of juvenile myoclonic epilepsy, they come to the attention because of the generalized seizures. Right, it is the generalized tonic-clonic seizures which will bring the patient to the doctor. See, what are the other two? Myoclonic jerks, right? A flickering of muscle contraction will be there, right? Flickering of the contraction of a single muscle fiber. That will not cause any abnormality, the abnormal activity within the individual, right? That will not impair the routine day-to-day activity. Which one? The myoclonic jerk. And he is not very much concerned about that myoclonic jerk. Absence seizure, like they'll just have a staring look for few seconds, and even patient doesn't know that what has happened during that time. Okay, and there is no postictal confusion if there is absence seizures. But generalized tonic-clonic seizures or generalized seizure, the individual will have involuntary movement all over the body, loss of postural control, he will fall down and he may have an injury also. So that will bring the patient to the doctor. Okay, and this particular generalized tonic-clonic seizures, they often occur upon awakening. Right, they often occur upon awakening, right? And these myoclonic jerks, if you see, myoclonic jerks where there will be contraction of the single group of muscle fibers, right? There will be contraction of a single group of muscle fibers. And usually these myoclonic jerks, they also appear in the morning, right? And where do you see these myoclonic jerks? These myoclonic jerks, they are very common in the arm. These myoclonic jerks, they are very common in the upper trunk. And these myoclonic jerks, let me tell you, they become more prominent with fatigue. Right, they become more prominent with fatigue, and these myoclonic jerks, they also get precipitated, or there will be increased episodes of the myoclonic jerks after alcohol ingestion. Right, there will be increased episodes of myoclonic jerks after the alcohol ingestion. So these are some of the features of the juvenile myoclonic epilepsy. And let me tell you, this particular juvenile myoclonic epilepsy which is seen in adolescents, they does not impair the intelligence of the individual. Right? Does not impair intelligence of the patient, right? And this juvenile myoclonic epilepsy, like as such, you don't have a progression of the disease, right? They tend not to be progressive, but sometimes infrequent seizures usually continues throughout the life, right? Throughout the life, they can have these particular episodes. And these patients with the juvenile myoclonic epilepsy, you need to know what will be the EEG abnormality. How do you diagnose? That is by EEG. EEG characteristically shows 4 to 6 Hertz irregular polyspike activity. Right? Irregular polyspike activity. And what will be the drug of choice for juvenile myoclonic epilepsy? That will be valproic acid. Right? That will be valproic acid. That will be the drug of choice for juvenile myoclonic epilepsy. Right? Then, having said, you see this question now. All of the following are the features of juvenile myoclonic epilepsy except myoclonus on awakening, yes, they are seen early in the morning. Generalized tonic-clonic seizures, yes, they will be there. Automatisms, they are not seen in case of juvenile myoclonic epilepsy. Absent seizures are also the part of the triad. So if you take these automatisms, as I already have said you just now, these automatisms, they are the features of the focal epilepsy, not juvenile myoclonic epilepsy. Right? This is a feature of complex partial seizures. And automatisms, they are involuntary, automatic behavior having wide range of manifestations. Right? Involuntary, automatic behavior having wide range of manifestations. And these particular automatisms, it may consist of very basic behaviors such as chewing movement can be there, lip smacking, there can be swallowing or picking movements of the hand, right? Or the picking movements of the hand. So that will be the automatisms, right? And you see the next question. True about juvenile myoclonic epilepsy is focal seizures, generalized seizures, myoclonus, response to sodium valproate, spike and wave EEG. So generalized seizure will be there, myoclonic jerks will be there, response to valproic acid also will be there, spike and wave pattern in the EEG also will be there, right? Having said this, let me discuss some most frequently asked questions on the topic of the juvenile myoclonic epilepsy. So most commonly affects which particular age group? That is the adolescents. And this juvenile myoclonic epilepsy, most commonly it is seen in the morning right? Most commonly it is seen in the morning after awakening. And these particular episodes, they can be precipitated by sleep deprivation. Right? They can be precipitated by sleep deprivation. And they have bilateral myoclonic jerks, right? Myoclonic jerks are present on both the sides. And in almost 90% of patients with the juvenile myoclonic epilepsy, they have the generalized seizures, that is generalized tonic-clonic seizures. And what about the consciousness? Consciousness of these individuals, they are usually preserved, right? They are usually preserved. And what about the family history? Family history of epilepsy is also common. Right? Family history of epilepsy is also common. And the EEG, what does it show? The EEG characteristically shows bursts of 4 to 6 Hertz irregular polyspike activity. Right? 4 to 6 Hertz irregular polyspike activity. And the drug of choice will be valproic acid. Right? Drug of choice will be valproic acid. So these are some of the most frequently asked questions on the topic of the juvenile myoclonic epilepsy.